All right, I would like to introduce our speaker today, Dr. Benjamin Natelson. He's the director of the Pain and Fatigue Study Center and professor of neurology at the Icahn School of Medicine at Mount Sinai. So Dr. Natelson will be talking about current clinical and research activities in Mount Sinai's Pain and Fatigue Study Center. So please take it away.
David, thanks so much. So the Pain and Fatigue Study Center has two limbs. One is clinical, and that, for all intent and purposes, right now is me and my nurse practitioner. But I'm hoping I'll be able to recruit another junior doctor to teach him or her how I approach ME/CFS. But for this talk, the most important limb is the research limb. And I want to tell you what we are doing at Mount Sinai. Mount Sinai now is located in the north part of Manhattan. And some of the studies we're doing require the research participant to be in our lab in New York. So I'm going to talk about those briefly. But if any of the people who watch this, I guess we can call it a webinar, live within 50 miles of Manhattan, and you have chronic fatigue syndrome, we want to study you. So we are now doing a number of studies funded by our federal government, the NIH. One of them is designed to look at this post-exertional malaise. And what we do in that study is give our research participants a wrist-mounted computer to provide data on how they feel over the day. And they do this for 8 days before we do stress testing. And then we do it for another 8 days out. And we're going to be able to look at the effect of a stress test, or actually there are two in a row, two stress tests in a row, in what happens to the baseline symptoms. Obviously, patients with ME/CFS have fatigue, many have brain fog. So we start with the baseline values, and then we see what happens after the stress test to see whether things get worse. And so we are going to be able, we're in the process now of figuring out a way to label individual patients as to whether they fulfill some criterion for PEM, and then look at how they performed on the stress tests. Very important studies done in collaboration with the brilliant and famous cardiologist, Donna Mancini. The other study, which just began July 1st, is doing brain imaging, MRI imaging, to look to compare patients with classical ME/CFS to patients whose CFS followed COVID. I call them PASC CFS, or long COVID CFS. And we've done a little bit of that already, and we do find some differences in the PASC CFS group. PASC stands for post-acute syndrome of COVID, and which we didn't find in our CFS group. But now we're just in the process of looking at volume of different parts of the brain. And as I might have suspected, there is some evidence for some involvement in the classical CFS patient and not in the PASC CFS patient in terms of reduction of volume. So we are continuing that study. So patients who have long COVID, severe enough to produce horrible fatigue, brain fog, and widespread pain consistent with the diagnosis of ME/CFS, we're going to compare you to patients whose illness began unassociated with COVID. And for all intent and purposes, that's before 2020. But obviously, there are cases that are coming in that I see who develop their ME/CFS symptoms after a virus unassociated with COVID. So the first thing I want to tell, so those are two ongoing studies where we need subjects, patients who have ME/CFS, and healthy controls for comparisons purposes, who do not exercise regularly. It's very important that we study sedentary healthy people, because people who are very fit are automatically very different from ME/CFS patients who, by the nature of their illness, are forced to rest a lot. So one thing we've been working on over the years, and still a very important subject for our research, is to look at the question of whether ME/CFS is the same or different from fibromyalgia. Now, using an early definition of how to identify fibromyalgia, there was a big difference. The rate of ME/CFS in a community study done by Lenny Jason years ago is about 0.4%. David and I were talking that there are more recent data that bring it up over 1%. Now, fibromyalgia, though, is much more common. If it was 0.4% for ME/CFS, it was 4% for fibromyalgia. And then the rheumatologists who've been involved in defining fibromyalgia got together and said, well, we really need to expand the diagnosis to include more people. So they started including fatigue and brain fog, so that their definition of fibromyalgia really approaches my definition of ME/CFS. So we use the original definition of fibromyalgia and try to compare patients who have ME/CFS without fibromyalgia to patients who have ME/CFS with fibromyalgia. And why are we doing this? Well, if the two ailments are the same, and some researchers just say, well, because they occur so often together, they're the same thing. If they're the same, that means that the underlying processes that produce the disease are the same. But if they're different, that means that the underlying processes are different, and so the treatments will be different. So this is a very important research question, and we found data supporting the fact that they were different, but we've also found some data, most notably in the spinal fluid protein array, that suggests they're similar. So there's more work to do on that front. The other study I want to talk to your listeners about is one that can be done anywhere in the continental United States. So San Diego, Manhattan, Louisiana, doesn't matter where. We're tooling up to do a study using vagus nerve stimulation to treat long COVID patients who are sick enough to fulfill criteria for chronic fatigue syndrome. And what we do is we screen them to make sure that they've been evaluated and they haven't had any medical cause that can be producing this long COVID. They weren't hospitalized, so they don't have lung disease, because, of course, if you're hospitalized from COVID, it can really mess up a lot of organs. Heart and lungs, number one. And if you have suffered COVID infection and have suffered problems with your heart or lungs, then that could certainly cause fatigue, disturbed sleep, etc. So we want to study patients who have long COVID with fatigue, brain fog, widespread pain, and post-exertional molestia. The big four symptoms that really allow one to identify chronic fatigue syndrome. And we are going to put them into one of two groups. One group, everyone will be getting this stimulator, which is essentially attached to the ear, And so it doesn't require implantation like the early ones did. It doesn't require holding it to your neck. You just can clip it on and walk away and let the device do its thing. So there'll be two groups, and we want to determine which of the two groups produces the best effect. One group is going to be the patient delivers the stimuli himself, herself, and the other, the device using the patient's threshold choice of stimulus intensity and the patient's resistance and a bunch of other factors picks the optimum set of stimuli to deliver. So this is going to be 6 weeks where if you live in San Diego or anywhere, we would mail the device to you. We would explain to you by a Zoom session how to use it. We would then have you use it, and toward the end of the study, we're going to look at a variable called heart rate variability. Let me just tell you what that means, that if you feel your pulse and take a slow breath in and a slow breath out, you feel your heart rate go up and then go down. That's called heart rate variability. And heart rate variability like that is giving us very strong information about the limb of the autonomic nervous system that is calming and anti-stress, this parasympathetic limb, to be contrasted with the other limb, which is the fight, flight, or sympathetic limb. So this is a way that we can assess remotely to see the effect of treatment on your parasympathetic tone. So we're very excited by this study because, pardon me, there are so few treatments for long COVID, and we did an early small study, and we did find some patients did a lot better on the vagus nerve stimulation. So again, this is a study that can be done anywhere in the continental United States. You do not have to come into Mount Sinai. And I should tell you, the way you communicate with us about any of our studies, the ones where you have to come in for stress testing and brain imaging, you just can email us at painandfatigue, pain, A-N-D, fatigue, at Mount Sinai, MOUNTSINAI.org, or call our research line, which is 212-844-6665. So that would put you in touch with our nurse practitioner, Michelle, who will talk to you and tell you about our studies. The other way to see what's going on in my laboratory, pardon me, is to put Natelson Lab Mount Sinai into Google, and that'll bring you to the Pain and Fatigue website on Mount Sinai, which lays out the clinical limb, what we do in the clinical limb, and the current research projects. So again, the things that we want to understand is how ME/CFS and FM are the same or different, and can we learn from the experiments that help us decide which of those questions is right. Treatments for each one. CFS patients often have a lot of bodily pain, and so many of them also have fibromyalgia, the way we define it in New York. And that's a very important research question. So we've been very lucky this year. We've gotten support from a number of patients to help us move ahead. You know, getting funding in ME/CFS is very hard. What a researcher does, he spends 3 months writing what's essentially a legal brief, telling the reviewer what it is that he wants to do. So, for instance, for our imaging study, we told them we wanted to look at how oxygen is used in the brain, and we want to look at the actual anatomy to see if there are any differences, and we want to see cerebral blood flow and see what the effect on cerebral blood flow is with something that we just discovered, pardon me, and that is that our ME/CFS patients, a good number of them, when we study them in the exercise lab, either are over breathing even before exercise, or breathing in a funny panting-like way that we think is inefficient or dysfunctional, and we're anxious to find out how the existence of these breathing conditions lead to worse health, because that's our hypothesis. If you're over breathing, or you're breathing in this dysfunctional way that's not smooth and regulated over time, we think that these breathing abnormalities may push your symptoms to be worse. So that's really it for starters, I think. I will say that we are also finishing a small study of oxaloacetate. My friend Cindy Bateman in Utah is currently doing a placebo-controlled trial of oxaloacetate, which is a chemical that's found to be reduced in ME/CFS. And our job was to look to see if patients taking the oxaloacetate had restored brain function toward normal, because we'd found some abnormalities in the ME/CFS patient, some brain abnormalities. And so the purpose of the supplement was to see if these abnormalities were swept away by the oxaloacetate. So right now, the oxaloacetate is available, but it's pretty pricey. And if the results of the studies are positive, and there's a need for it in ME/CFS, I'm very hopeful that the price will make it affordable. Right now, at the doses we use, it's very expensive. So let's stop here for a minute and see if any of the people who are online, and there are 20 of us, 18 of us, not counting David and me, have any questions about what I've said so far. David, you'll let me know, okay?
Okay. Yeah, I'm monitoring the chat. I haven't seen any questions come through yet. If anybody has a question, they feel free to. Oh, there we go. Question would be, how would oxaloacetate become more affordable? Through insurance?
I'm not sure about that. I think first of all, it's a medicinal food. It's a supplement, so insurance doesn't cover that. But if and I'm not sure what the manufacturer is going to do, what his plans are. If his plans are to get it FDA approved, then insurance would cover it. But if that is not going to happen, then because it's been shown to be efficacious, I think they'll make a version of it that ME/CFS patients can get that will make it less expensive than if you just go to the current website.
Yeah, I actually had a conversation with the CEO of the group that makes oxaloacetate, and he said that right now it's expensive mainly because of low volume. So
Right.
if it does prove to be useful, and obviously then a lot more people are going to want to try it and take it, the volumes might allow them to reduce their prices. So.
Yeah, I think that's it. I mean, it's a business. He's in business and he wants to make a profit. The email address. Okay, so it's pain and fatigue. PAINandFATIGUE. Pain and fatigue at mountsinai.org. MOUNTSINAI.org. And you can't abbreviate. The emailer will hate that. And our phone number is 212-844-6665. Now, I can't see the other questions, David. They've come through too quickly for me.
It's okay. I'll read them off to you. Second question was, is the vagus nerve stimulation study only for long COVID patients?
That's correct. Long COVID patients who are so ill that they fulfill criteria for the diagnosis of ME/CFS. Yeah, we really need to have, I have to tell you, as a doctor who sees these long COVID patients, I have to treat them the same as my CFS patients, which means that every patient gets my personalized medicine approach, but there's no specific treatment. It depends on what's bothering the patient. Is it brain fog? Is it feeling awful when they're on their feet not moving, which is an indication of orthostatic intolerance? Is it fatigue? But since we did our little pilot study on long COVID CFS patients and found that a good chunk of these patients got better, this study is going to be focusing on them. And in terms of who has horrible medically unexplained fatiguing illness, the long COVID patients overwhelm the non-long COVID ME/CFS. The rate is 0.4, somewhere between 0.4 to 1% of the population has ME/CFS, and it's thought to be 7 to 10% of COVID survivors who are not hospitalized have long COVID. So that's a huge difference in number. So, and these patients really do not have a treatment. So my focus is, how can we get something that works? Well, we'll see if it works. Available for the long COVID CFS patient.
One thing I'm curious about the numbers. I've heard the numbers that you just spoke about, but then the numbers from the Kaiser study where they were looking at all a large group of patients in Kaiser, they found that only 14% of the people in Kaiser that had ME/CFS had long COVID. So it seems like we still have a much larger cohort of people with pre-COVID ME/CFS than we do with COVID.
Yeah, but that may just be that healthcare system.
Okay.
I mean, and the numbers you cited, you cited some source that had it over 1%.
The CDC, I think, says one. The CDC, I think, is currently at 1.3%.
Yeah. Well, I mean, all I know is Lenny Jason did random digit dialing of people and determined the rates of CFS, and it was 0.4%. It was something like 0.6 in women and 0.2 in men. So it's not a common illness, but common enough, God knows. And I, frankly, continue to believe that long COVID is way more common in terms of producing ME/CFS. In the first published study we did, in which we looked at how patients with long COVID and chronic fatigue syndrome were able to do in terms of stress testing, we found that nearly half fulfilled criteria for ME/CFS. That's a lot. And again, a bunch of them, a big number, and we're writing those data up right now, have breathing abnormalities. And one research question is, what do those breathing abnormalities do? Are they responsible for worse symptoms? And we do have a little bit of pilot data now that indicate that patients whose breathing is abnormal complain of more shortness of breath than patients whose breathing is normal. So this is something that we've identified as and considered to be an illness multiplier. And what's very important about these two breathing abnormalities is they're treatable. So I'm working with a fabulous researcher who has a method for treating these, and now we're in the process of putting a grant together to go to NIH to support doing a study to look at how to improve the breathing patterns of ME/CFS patients and to see whether improving their breathing patterns improves their health.
Okay. Next question. Do you have to have a firm ME/CFS diagnosis to get into the study?
Absolutely. I am a researcher. And so if given 100 patients and only 20 of them follow my rigid criteria for diagnosing ME/CFS, those are the only patients we want to study. Let me give you an example. So with the drug penicillin, if you treat, I'm going to use treatment as an example. If you treat 100 people with a sore throat, maybe 40 or 50 of them, if you treat them with an antibiotic, maybe 40 or 50 of them are going to get better. But if you know that they have a strep infection, 100% of them are going to get better. So what we need are criteria, biomarkers, and my colleague Steve Schutzer and I are just finishing a study looking at spinal fluid proteins, trying to come up with a set of proteins that are specific to ME/CFS and differentiate ME/CFS from both healthy controls and people with other neurological diseases that produce fatigue, such as multiple sclerosis. And so we're hoping in the next 6 months to have a short list of proteins that can be used as biomarkers, and those will be very important to try to move the diagnosis of ME/CFS from a clinical diagnosis to a lab test diagnosis.
Okay. Next question. Could the length of time with illness be a reason that the brain volume is different between PASC ME group and the classical ME group?
Yeah, that's a great question. I mean, that's an obvious variable we would like to look at, duration of illness. And the answer is, of course, I was looking at a movie the other day on Muhammad Ali, that when he was Cassius Clay even, and he was just, the most lithe person. And then late in his life, when the damage done to his brain by repeated blows to the head happened, he was not obviously the same person. So we can expect, if there's something simmering in the brain, that longer is worse.
Okay. Next question. If you're talking about the possibility of ME/CFS and fibromyalgia being the same condition, are you looking at the possibility of ME/CFS and POTS being the same condition?
Well, POTS I see as a subset of patients with ME/CFS. In other words, and POTS, by the way, is not the most common orthostatic abnormality. The most common orthostatic abnormality, and the one that actually causes POTS, is orthostatic overbreathing. So let me just go through the biology so you understand what orthostatic or gravitational stress is. So when the first thing is, when your body has nutrients, the byproducts in the cell are carbon dioxide and water. And the carbon dioxide goes into the bloodstream, goes to the lungs, and if the lungs are healthy, it's exhaled and a level is kept. I'm going to tell you numbers, even though they won't be meaningful to you, but the level that we look for is between 35, say, and 42. People who have lung disease, chronic obstructive pulmonary disease, COPD, their lungs are not normal. So when the blood brings the CO2 to the lungs, there are no blood vessels there to accommodate it. So the CO2 in the body goes up, and that eventually is responsible for illness and even death in COPD patients. But what happens in some patients is they overbreathe. Some patients overbreathe when they're just sitting quietly, and others don't overbreathe until they undergo gravitational stress. And the gravitational stress that I and my colleagues use at home is a lean test. And we like a lean test because it's sort of like a tilt table test without having to actually have the tilt table. So any clinical patient I see, I ask them to put a blood pressure cuff on above the elbow on the upper arm, and then lie quietly for 10 minutes, and then give me 3 1-minute readings of blood pressure and heart rate, and then stand up, feet about 6 inches away from the wall, with only the shoulders touching the wall, so that they're leaning essentially against the wall, and then repeat the blood pressure and heart rate every minute for 10 minutes. Now that will let you capture orthostatic tachycardia or POTS, but obviously it will not let you capture an abnormality of breathing, because for that you need to have a device that actually records the exhaled CO2. Now, we are currently in our PEM study. The PEM study is the one I told you where we're looking at symptoms before and after doing 2 stress tests. In that study, we can capture, again, post-exertional malaise and use it to determine how to break it up.
Just to follow up on that one, would you need to detect the CO2 in the exhale, or would you be able to measure the O2 saturation in the body itself?
Okay, so O2 saturation and exhaled CO2 are 2 very different things. O2 saturation is very easy to measure with these little finger devices that are now all over. And obviously, if your O2 saturation falls under 92 or 91, that's can be worrisome. But exhaled CO2 is a totally different thing. So all my patients have normal oxygen in their body, but some of them overbreathe. And when you overbreathe, and this is what my colleague Julian Stewart has shown, it's the overbreathing, the drop in the end-tidal CO2, so-called hypocapnia, that makes the heart rate race. And the biology of orthostatic intolerance is partially due to the fact that when you go from lying to standing, you move a pint of blood from your chest into your legs and into the bottom of your gut, and if you're a woman, or the vessels around your ovaries. And if you're resting a lot, which is, of course, part and parcel of what it is to have ME/CFS, then the consequences of resting are significant. In fact, NASA uses bed rest to emulate life in space, because bed rest produces the same sort of deconditioning that life in space does. So that then, if someone's blood volume is reduced, which is what happens when you rest. And the other things that happen when you're in space, or if you have ME/CFS, is that your heart gets smaller and the ability of your heart to work gets less. When someone then stands up and puts a pint of blood in their lower part of their body, then their chest says, "Where's the blood?" And the patient begins to overbreathe first and then develop a faster heart rate, because both of those manipulations bring blood into the chest and into the brain.
Interesting. Okay. Next question. Is dichloroacetate an option or a PDH or PDK drug?
I don't know what those are, sorry.
Yeah, I don't, unfortunately, either. Okay, we'll move on. For the vagus nerve, if you've had ME/CFS for 10 years and then wound up with long COVID, can you participate?
Nope.
Alrighty.
That's not, you see, let me explain to the people listening to this webinar. I'm a researcher, and I have to be rigid about the kind of patients that I study, or else it's a little bit like I was telling you with the penicillin study with the sore throat. ME/CFS is can be caused by many things, and we don't know. The things that are important about long COVID CFS is we know that every patient had an infectious onset, 100%, and we know the illness duration is reasonably short. Since 2020, it's already moving now into 4 years. With a patient who has ME/CFS that started before 2020, we can't be sure they had an infectious onset unless their illness started with an illness like mono. And they have many years of illness, and horrible illness for many years have their own secondary effects on the human being, as you can expect. So we have to be very rigid in who we study, or else we risk the study being negative. If we bring in too many cases that are different from the ones we need to focus on, we risk interfering with the therapeutic effect we're seeking.
Got it. Okay, next question. Is there an interest in what's causing the mitochondria to become damaged or stop producing ATP and oxygen, like viruses?
Well, we don't, the studies that we did in the brain 10 years ago didn't show any mitochondrial abnormalities in the brain. ATP was normal. We did some studies many years ago looking at exercising muscle, and we thought we found a mitochondrial abnormality, but then on careful retesting, we didn't. So I really don't know if there's a mitochondrial abnormality in ME/CFS. That's a research question yet to be answered.
Okay.
David, I'm good for another 5 minutes.
Alrighty. Well, I think we've just got a few more questions, so we'll try and get
Great.
through as quick as we can. One question, how can we get a firm ME/CFS diagnosis if there are no clinicians who are capable of diagnosing it within our area?
That's a great question. Well, I published, I can't tell you where. It's really pretty simple. And I just don't have the publication handy, but I've published a way to just step through using criteria that originally the CDC developed, and I can tell you them sort of over the phone, as you will. The first thing is, does the fatigue produce a substantial decrease in your activity in one of 4 spheres: social, personal, educational, or workplace? So we operationalize that by asking patients, giving them a scale from 0 to 5, where 0 is none, 3 is substantial, 4 severe, 5 very severe. And so we are to make that the life spheres criteria. They have to the patient has to say he or she has had a substantial, severe, or very severe reduction in activity in one of those 4 spheres. And then we have 8 symptoms that were published in the 1994 case definition. And I think I can rattle them off. Well, actually, I'm going to give you all 10 symptoms because the 1988 case definition had 10 symptoms, and the 1994 case definition dropped 2 of them. But I'm always interested in all of them, so I'll go through them. We ask patients to rate on a 0 to 5 scale, which is none, mild, moderate, substantial, severe, or very severe, the following questions, and I hope I give you 10 of them. Feverishness, sore throat, tender glands, headache, achy muscles, achy joints, muscle weakness that is not fatigue, brain fog, which is really difficulty with attention and concentration, unrefreshing sleep, and then this horrible post-exertional malaise, which essentially puts people to bed or need to rest after relatively minimal physical or emotional activities. And then we ask patients to rate them. And if they rate of the 8 symptoms, for the 8 symptoms, we don't count weakness and feverishness. And this will be for the 1994 case definition. If they give us at least a 3 on 3 of those 8 symptoms, and at least a 2 on one of them, that's CFS. So you don't really have to, it's not fancy, it's not hard. You just have to know how to go through it step by step. Life areas affected by horrible fatigue, and then other symptoms besides the fatigue have to occur at a substantial or moderate severe burden to the patient.
Okay, so using that criteria, you feel that any clinician, even one who's not experienced in ME/CFS, can then diagnose it?
That's correct. I mean, the best way to do it is to have it on a card. And so in the publication I did, and I just can't cite the publication, we put a copy of the card that I hold in front of every patient, which shows the 0 to 5 scale when I go through all those symptoms. Now, the Institute of Medicine simplified the diagnosis by only requiring 6 months of fatigue limiting activity in one of those spheres, and then problems with unrefreshing sleep. I can't remember, unrefreshing sleep, and then brain fog, and then report of unrefreshing sleep or post-exertional malaise. Those are 2 required symptoms that have to be substantial or greater, and then either brain fog or the report of feeling worse during gravitational stress. So they've simplified it, but we continue to use I collect symptoms based from 1988, so I have every symptom, and I can see what's what for the individual patient.
Okay. So I know you had to leave. I just want to check on your time here. Do you want to take any more questions, or do we?
I can take let's say 1 or 2 more.
All right. So we have one more question about your stress test study. They were wondering, will it also help diagnose POTS, or will this hopefully help diagnose patients in the future?
So we assess every patient we see for POTS. The exercise study is not useful in identifying POTS. And again, POTS is not the big driver. The big driver is POTS stands for postural orthostatic tachycardia syndrome. We have named the overbreathing that happens during gravitational stress as POSH, postural orthostatic syndrome of hyperventilation. And again, since doctors are unable to assess breathing, they're missing many patients who have orthostatic intolerance evident by reduced carbon dioxide, exhaled carbon dioxide during the lean test.
Okay. Excellent. Thank you very much, Dr. Natelson. This has been very informative, and we will try and publish the contact information that people can get a hold of your clinic if they want to try and participate in some of your studies.
Great. So you'll give them the website for my lab, and
Yes.
then you'll give them the pain and fatigue at mountsinai.org and the phone number.
Yes, we definitely will.
Super. Holcombs, thank you very much for asking me to be your #1 person to do this. I think, David, you made it happen. So thank you very much to all of you.
I
Bye
give my
now.
credit to my wife. Thank you very much. Bye-bye. Thank you, everyone, for attending.